Welcome to Strides to Solutions, where we explore the intricate pathways of human psychology and physiology to better understand how we can support healing and resilience. I'm your host, Esther Adams, and today we're diving deep into one of the most overlooked yet critical connections in healthcare: the relationship between chronic pain and sleep disturbance. If you've ever experienced persistent pain that seems to worsen when you're tired, or found yourself lying awake because discomfort won't let you rest, you're witnessing firsthand what researchers have been mapping in extraordinary detail over the past decade. What we're discovering challenges the traditional view that pain simply disrupts sleep as a side effect. Instead, we're uncovering a complex, bidirectional relationship where poor sleep actually intensifies pain sensitivity, creating what many specialists now recognize as a self perpetuating cycle. Let's begin by understanding what's happening in your brain when pain and sleep problems intersect. This isn't just about being uncomfortable. We're looking at fundamental changes in how your nervous system processes information and regulates itself. The research reveals that chronic pain and insomnia share overlapping neural circuits, particularly in three key brain regions. The anterior cingulate cortex, which sits like a bridge between emotional and cognitive processing, becomes hyperactive when both conditions are present. Think of it as an alarm system that's stuck in the on position, constantly scanning for threats and amplifying both pain signals and sleep disrupting arousal. The nucleus accumbens, traditionally known for its role in reward and motivation, contains specialized groups of neurons that regulate both pain like behaviors and sleep wake cycles. These neurons send different projections, some toward brain regions that process pain, others toward areas that control sleep. When this system becomes dysregulated, it creates a neurobiological tug of war between your need for rest and your experience of discomfort. The amygdala, our brain's fear and emotion center, undergoes structural and functional changes in both chronic pain and chronic insomnia. It becomes hypervigilant, interpreting neutral sensations as potentially threatening and maintaining a state of physiological arousal that makes restorative sleep nearly impossible. But the story doesn't end with these brain regions. The entire neurochemical landscape shifts when pain and sleep problems coexist. Dopamine, crucial for motivation and arousal regulation, becomes imbalanced. Serotonin, which influences both mood and sleep cycles, shows altered patterns of activity. GABA, our brain's primary calming neurotransmitter, becomes less effective at promoting the relaxation necessary for sleep. Norepinephrine keeps the nervous system in a heightened state of alertness, while glutamate, the brain's main excitatory chemical, contributes to a process called central sensitization, where your nervous system becomes increasingly reactive to stimuli that shouldn't normally cause pain. This neurobiological understanding helps explain why traditional approaches that treat pain and sleep as separate problems often fall short. We're not dealing with two distinct issues that happen to occur together. We're dealing with overlapping systems that influence each other at the most fundamental level. One of the most significant discoveries in recent years involves the hypothalamic pituitary adrenal axis, your body's primary stress response system. When functioning normally, this system follows a predictable rhythm. Cortisol, our primary stress hormone, peaks in the morning to help us wake up and gradually declines throughout the day, reaching its lowest levels at night to allow for restorative sleep. Chronic pain disrupts this rhythm in complex ways. Sometimes we see what researchers call a blunted cortisol response, where the normal daily fluctuation becomes flattened, leaving individuals in a state of chronic low-level stress activation. Other times, particularly when anxiety and depression are also present, we see elevated cortisol reactivity, where the system becomes hyper-responsive to stressors, including pain itself. This matters tremendously for sleep. Poor sleep quality amplifies how intensely your stress system responds to pain. When you're sleep deprived, your cortisol reaction to painful stimuli becomes exaggerated, which in turn makes you more sensitive to pain. It's a biological feedback loop where each component reinforces the others. The research shows us something particularly striking about sleep duration and pain sensitivity. People who get adequate sleep, typically 7 to 8 hours, show better ability to cope with painful stimuli and less cortisol reactivity to stress. But as sleep becomes fragmented or shortened, this protective effect disappears. Your threshold for pain drops, and your stress response becomes amplified. This helps explain why pain often feels worse when you're tired and why a poor night's sleep can set you up for a more difficult day with pain management. Your nervous system is operating in a state of heightened reactivity, interpreting signals as more threatening than they would be if you were well rested. Let me introduce you to one of the most important concepts in modern pain science: central sensitization. Under normal circumstances, your nervous system has built in protective mechanisms. When you experience pain, your body also activates systems designed to limit that pain response and help you cope with it. But in chronic pain conditions, especially when sleep is poor, these protective mechanisms can become overwhelmed. Central sensitization occurs when your nervous system becomes increasingly sensitive to stimuli. Areas of your body that shouldn't be painful become tender. Light touch might feel uncomfortable. Temperature changes that wouldn't normally bother you become distressing. Your pain threshold drops, and your pain response becomes amplified and prolonged. The research demonstrates convincingly that sleep disruption directly contributes to central sensitization. When people are experimentally sleep deprived, even for just a few nights, they show increased sensitivity to painful stimuli and decreased ability to inhibit pain signals. This isn't just about being tired and therefore less able to cope with discomfort. It's about fundamental changes in how your nervous system processes sensory information. This process involves several mechanisms. Sleep disruption triggers activation of glial cells, the support cells in your nervous system that, when activated, contribute to neuroinflammation. This low grade inflammation in your nervous system creates an environment where pain signals are amplified rather than properly regulated. Sleep deprivation also impairs your brain's ability to activate descending pain inhibition, the top down systems that help dampen pain signals. Think of it like losing the volume control on your pain experience. The signals keep coming, but your brain's ability to turn down the volume becomes compromised. The dopamine system, which plays a crucial role in pain modulation and motivation, becomes disrupted with chronic sleep loss. This affects not only your pain experience, but also your capacity to engage in activities and behaviors that might help manage pain. Understanding central sensitization helps explain why people with chronic pain often develop sensitivity to multiple types of stimuli, why their pain can spread to new areas of the body, and why traditional pain relief methods sometimes become less effective over time. It also explains why improving sleep quality can be such a powerful intervention. It addresses one of the key drivers of nervous system hypersensitivity. While the biological mechanisms of the pain sleep connection are fascinating, we cannot understand this relationship without examining the cognitive and emotional factors that mediate and amplify it. The research reveals that certain patterns of thinking and emotional responses act as bridges between pain and sleep problems, often determining whether someone gets caught in a chronic cycle or finds pathways toward improvement. Catastrophizing stands out as one of the most significant psychological factors. This involves the tendency to magnify the threat value of pain, to ruminate on it, and to feel helpless in managing it. Thoughts like, this pain will never get better, I can't handle this, or something terrible must be wrong with me, create a state of cognitive and emotional arousal that interferes with sleep while simultaneously amplifying the pain experience. The research shows us that catastrophizing doesn't just correlate with worse pain and sleep, it actually mediates the relationship between them. In other words, catastrophizing helps explain why pain leads to sleep problems and why poor sleep leads to increased pain. When your mind is caught in cycles of worry and negative prediction, your nervous system remains in a state of hypervigilance that makes both pain management and sleep initiation extremely difficult. Hypervigilance represents another crucial piece of this puzzle. This involves an excessive focus on bodily sensations and potential threats. When you're hypervigilant about pain, you're constantly monitoring your body for signs of discomfort, which paradoxically can amplify your perception of those sensations. When you're hypervigilant about sleep, you're constantly checking whether you're falling asleep, how much sleep you've gotten, how tired you feel, all of which creates a state of arousal that works against the relaxed awareness needed for healthy sleep. Pre-sleep cognitive arousal emerges as a particularly powerful predictor of both worsening pain and sleep problems. This involves racing thoughts, worry, planning, or rumination in the period before attempting to sleep. Your mind might be processing the day's pain experiences, worrying about tomorrow's challenges, or simply unable to quiet the mental chatter that chronic pain often generates. This cognitive activation is incompatible with the neural processes required for sleep initiation. The research reveals interesting patterns in how these cognitive factors develop and maintain the pain sleep cycle. Poor sleep impairs cognitive flexibility and emotional regulation, making it harder to challenge catastrophic thoughts or disengage from worry. Meanwhile, increased pain intensity fuels more catastrophic thinking and hypervigilance, creating more cognitive arousal. It becomes a self reinforcing cycle where each component feeds the others. Cognitive biases also play a role. People with both chronic pain and insomnia show heightened attention to pain related information and sleep related threats. They're more likely to interpret ambiguous situations negatively and to remember pain and sleep difficulties more vividly than positive experiences. These biases aren't character flaws, they're understandable adaptations to chronic threat that unfortunately can perpetuate the very problems they're trying to solve. Depression and anxiety don't just accompany chronic pain and sleep problems, they actively mediate and moderate the relationships between them. Think of mood disorders as both consequence and cause in this complex interplay. The research consistently shows that depression and anxiety act as pathways through which pain and sleep problems influence each other. When someone develops chronic pain, the risk of depression increases significantly. Depression then makes sleep problems more likely while also increasing pain sensitivity. Similarly, chronic insomnia increases the risk of both depression and anxiety, which in turn can amplify pain experiences. But mood disorders don't just mediate these relationships, they also moderate them, meaning they change how strongly pain and sleep problems affect each other. Someone experiencing depression along with chronic pain is more likely to develop severe sleep disturbances than someone with pain alone. The presence of anxiety can intensify how much sleep problems affect pain sensitivity. Network analyses of symptoms reveal something particularly important. While pain and sleep problems might not always be directly connected in people's experience, they're consistently linked through mood symptoms. Depression and anxiety act as bridge symptoms, creating indirect pathways between pain and sleep disturbance. This helps explain why addressing mood symptoms can sometimes create improvements in both pain and sleep, even when those aren't the primary treatment targets. The gender differences in these relationships are striking and clinically relevant. Research shows that rumination, repetitive, negative thinking about problems and their consequences, is a stronger mediator between insomnia and pain in females, while depressed mood is more prominent in males. This suggests that interventions might need to be tailored differently based on gender, focusing more on rumination and repetitive thinking patterns for females, and more on mood regulation for males. The temporal aspects of mood mediation are also important. Mood symptoms often predict future changes in pain and sleep more strongly than current pain, or sleep problems predict future mood changes. This suggests that mood might be an upstream factor in the development and maintenance of pain sleep cycles, making it a crucial target for early intervention. Understanding these mood connections helps explain why people with chronic pain and sleep problems often feel caught in a web of interconnected difficulties. It's not just that they're dealing with multiple separate problems, they're dealing with symptoms that actively reinforce each other through mood related pathways. This can create a sense of being trapped, where improvement in one area feels impossible because of the ongoing influence of the others. One of the most fascinating and clinically relevant aspects of the pain sleep connection involves the beliefs people hold about these relationships. Maladaptive, sleep related beliefs, particularly those connecting pain and sleep, play a central role in perpetuating insomnia among people with chronic pain. These beliefs might include ideas like, I can't sleep when I'm in pain. If I don't sleep well tonight, my pain will be unbearable tomorrow. I need complete pain relief to get good sleep. Or, poor sleep means I'm making my condition worse. While these beliefs often contain kernels of truth based on lived experience, when they become rigid and absolute, they can create psychological and physiological states that make sleep more difficult. The research reveals that these beliefs don't just correlate with worse sleep, they actually mediate the relationship between pain severity and insomnia. In other words, maladaptive beliefs about sleep help explain why some people with chronic pain develop severe insomnia, while others with similar pain levels maintain better sleep quality. These beliefs create several types of problems. They increase pre sleep anxiety and cognitive arousal, as people worry about whether they'll be able to sleep and what will happen if they don't. They lead to counterproductive behaviors like spending excessive time in bed trying to catch up on sleep, taking multiple naps, or rigidly controlling the sleep environment in ways that can actually interfere with natural sleep processes. Perhaps most importantly, these beliefs can create self fulfilling prophecies. When you believe strongly that pain will prevent sleep, you approach bedtime with anxiety and hypervigilance that activate your nervous system in ways that actually do interfere with sleep. When you believe that poor sleep will inevitably worsen your pain, you may interpret normal variations in pain as confirmation of this belief, potentially amplifying your pain response through expectation and attention. The cognitive behavioral model helps us understand how beliefs, behaviors, and physiological responses interact to maintain sleep problems. Maladaptive beliefs lead to unhelpful behaviors and increased physiological arousal. These create actual sleep difficulties, which then seem to confirm the original beliefs, strengthening them further. This understanding has profound implications for intervention. Simply telling someone that their beliefs are wrong is rarely helpful and can feel invalidating given their lived experience. Instead, the most effective approaches help people develop more flexible, balanced beliefs that acknowledge the real connections between pain and sleep while reducing the anxiety and behavioral responses that can make sleep more difficult. The research shows that when people develop more adaptive beliefs about sleep, such as sometimes I can sleep despite pain, poor sleep is frustrating but manageable, or my sleep can improve even if my pain doesn't disappear completely, they experience significant improvements in sleep quality and duration. Given the complexity of the pain sleep relationship, it might seem like effective treatment would require equally complex interventions. However, the research reveals some surprisingly clear patterns about what works best. Cognitive behavioral therapy for insomnia, known as CBTI, emerges as the most effective single intervention for sleep problems in people with chronic pain. The effectiveness is remarkable. People with chronic pain and insomnia show improvements in sleep quality, sleep efficiency, and overall sleep satisfaction that are comparable to those seen in people with insomnia alone. CBTI works by addressing multiple components of the pain sleep cycle simultaneously. It helps people develop more adaptive beliefs about sleep and pain. It teaches specific techniques for managing pre sleep cognitive arousal and worry. It includes behavioral interventions like sleep restriction and stimulus control that help rebuild healthy sleep associations. It addresses the physiological arousal that interferes with sleep through relaxation training and sleep hygiene education. What's particularly encouraging is that CBTI produces improvements in sleep that are generally sustained over time. Unlike medications, which typically only work while you're taking them and may lose effectiveness over time, the skills and insights gained through CBT I continue to benefit people long after the active treatment period ends. The effects on pain are more modest but still meaningful. While CBTI doesn't typically produce dramatic reductions in pain intensity, many people report that their pain becomes more manageable when their sleep improves. They have better energy for pain management activities, improved mood and coping resources, and reduced pain related disability. Interestingly, combined treatments that address both pain and sleep simultaneously don't always produce better outcomes than CBTI alone for sleep problems. This suggests that improving sleep quality may be one of the most efficient ways to break into the pain sleep cycle, even when pain remains present. Other non pharmacological approaches show promise as well. Exercise interventions, when appropriately adapted for people with chronic pain, can improve both sleep quality and pain management. Relaxation training, mindfulness based interventions, and stress management programs address the hyperarousal that maintains both pain sensitivity and sleep difficulties. The research consistently shows that non pharmacological approaches are not only more effective than most medications for sleep problems in chronic pain, they're also significantly safer. They don't carry risks of dependence, tolerance, or withdrawal. They don't interact with other medications. They often provide benefits beyond sleep and pain, including improved mood, better stress management, and enhanced overall quality of life. While non pharmacological approaches show the strongest evidence, many people wonder about the role of medications in managing the pain sleep connection. The research reveals a complex picture that challenges some common assumptions. Most medications traditionally used for sleep problems in chronic pain show limited effectiveness and significant drawbacks. Commonly prescribed antidepressants like amitriptyline, while sometimes helpful for pain, show little to no significant benefit for sleep quality in chronic pain populations. This is important because these medications are often prescribed specifically because doctors hope they'll address both pain and sleep, but the evidence doesn't support this expectation for sleep benefits. Opioid medications, still sometimes used for severe chronic pain, actually tend to worsen sleep quality over time. They can cause sleep fragmentation, reduce deep sleep stages, and create a cycle where people need increasingly higher doses to achieve the same pain relief while their sleep quality continues to deteriorate. Traditional sleep medications like benzodiazepines or newer Z drugs like zolpidem provide temporary relief but can create dependence and may actually interfere with the natural sleep processes that support pain recovery. They can also lose effectiveness over time, leaving people with both tolerance to the medication and worsened underlying sleep problems. Some medications show more promise. Pregabalin and gabapentin, which affect nerve signal transmission, can moderately improve both pain and sleep in certain populations, particularly those with neuropathic pain. However, they come with their own side effects and aren't universally effective. The research suggests that when medications are used, they're most effective as part of a comprehensive approach that includes behavioral and psychological interventions. Medications might provide short term relief that allows people to engage more fully with CBTI or other non pharmacological approaches, but they're rarely sufficient on their own for long term improvement in the pain sleep cycle. This evidence has important implications for treatment discussions. While medications can play a role, particularly during acute exacerbations or while learning new sleep skills, the most effective long term approach typically emphasizes non pharmacological interventions as the primary strategy. The pain sleep relationship isn't uniform across all people. Research reveals important differences based on gender, age, and individual characteristics that have significant implications for understanding and treatment. Gender differences are particularly striking. Females show stronger connections between sleep problems and pain intensity, and these relationships appear to be mediated by different psychological pathways. For females, rumination and repetitive thinking patterns are stronger mediators between insomnia and pain, while for males, depressed mood plays a more prominent role. Sleep disruption also enhances different aspects of central sensitization in males and females. This suggests that poor sleep may increase chronic pain risk through distinct pathways in each gender, which could have implications for how interventions are tailored. These differences likely reflect both biological factors, such as hormonal influences on sleep, pain processing, and mood regulation, and psychosocial factors, such as different cultural expectations around pain expression and sleep complaints. Developmental factors are equally important. The pain sleep relationship appears to be particularly strong during adolescence, a period when sleep patterns are naturally shifting and pain sensitivity may be heightened. Adolescents who develop insomnia show increased risk for developing chronic pain conditions, and those with pain conditions are at high risk for sleep problems. The cognitive and emotional mediators of the pain sleep relationship also appear to develop over time. Young people may be particularly vulnerable to developing catastrophic thinking patterns and hypervigilance that can entrench the pain sleep cycle early in life. Individual differences in pain sensitivity, sleep needs, stress reactivity, and coping resources all influence how the pain sleep relationship manifests for different people. Some individuals appear to be more vulnerable to developing central sensitization in response to sleep disruption. Others show greater resilience and maintain better sleep quality despite significant pain. Understanding these individual differences is crucial for personalized treatment approaches. Interventions that work well for one person may need significant modification for another based on their specific pattern of symptoms, mediating factors, and personal resources. One of the most hopeful aspects of current research involves understanding the brain's capacity for change, neuroplasticity, in the context of chronic pain and sleep problems. While the brain changes that maintain the pain sleep cycle can seem daunting, they also point toward the possibility of positive change. The same neural circuits that become dysregulated in chronic pain and insomnia can be retrained through appropriate interventions. CBTI, for example, doesn't just improve sleep behavior, it appears to produce measurable changes in brain activity patterns, particularly in regions involved in arousal regulation and pain processing. The stress response system, while disrupted in chronic pain insomnia cycles, can regain more normal functioning when sleep quality improves. People who successfully improve their sleep often show restoration of more normal cortisol rhythms and reduced stress reactivity. Central sensitization, while a serious complication of chronic pain, isn't necessarily permanent. Improving sleep quality appears to reduce nervous system hypersensitivity over time, though this process often takes weeks to months rather than days. The cognitive and emotional patterns that maintain pain sleep cycles are also changeable. People can learn to recognize and modify catastrophic thinking patterns, reduce hypervigilance, and develop more adaptive beliefs about pain and sleep. These changes often have cascading positive effects on both sleep quality and pain management. This neuroplasticity perspective is empowering because it suggests that even long-standing pain sleep problems can improve with appropriate intervention. The brain that has learned to maintain a chronic cycle of pain and sleep disturbance can also learn new patterns of functioning that support both better sleep and better pain management. However, this change typically requires sustained effort and often professional guidance. The neural pathways that maintain chronic problems have been strengthened over time and don't change overnight. Successful intervention usually involves consistent practice of new skills and gradual reshaping of both brain function and behavioral patterns. What emerges from this comprehensive look at the pain sleep connection is a picture that's both sobering and hopeful. Sobering because it reveals how complex and self reinforcing these problems can become. Hopeful because it shows us specific evidence based pathways toward improvement. Understanding the bidirectional relationship between pain and sleep helps explain why people caught in this cycle often feel stuck and why simple solutions rarely work. It's not a matter of just relaxing or pushing through the pain. These are complex neurobiological and psychological processes that require understanding and skillful intervention. The research reminds us that healing is not just about eliminating symptoms, but about restoring function, meaning, and quality of life. For many people dealing with chronic pain and sleep problems, this broader definition of recovery offers a more achievable and ultimately more satisfying goal than the pursuit of complete symptom elimination. Before we close, I want to share something that connects directly to what we've been discussing today. The power of reframing, changing how we interpret our experiences, emerges repeatedly in the research on breaking pain sleep cycles. Those maladaptive beliefs we discussed, the catastrophic thinking patterns, the way we narrate our relationship with pain and sleep, these are all examples of frames that can trap us or liberate us. I've just released The Big Book of Reframes, which takes this concept far beyond pain and sleep into every area where perspective shapes our experience. While today we focused on the specific neuroscience of pain sleep connections, this book explores the broader science of how reframing transforms our emotional health, relationships, and resilience. It's grounded in the same evidence based approach we've taken today, drawing from cutting edge research in psychology and neuroscience to show how consciously shifting perspective can change not just how we think, but how our nervous system responds to life's challenges. The book is available now on Amazon, and unlike superficial positive thinking approaches, it's built on rigorous research about how our brains construct meaning and why we have more control over our interpretations than we might realize. If today's discussion resonated with you, you might find value in exploring how these principles of cognitive flexibility apply more broadly to stress, relationships, and personal growth. This concludes our exploration of the intricate connections between chronic pain and sleep disturbance. Thank you for joining me on Strides to Solutions. Remember that while the science provides the roadmap, each person's journey toward better sleep and pain management is unique. The evidence gives us hope and direction, but healing ultimately happens through the patient work of applying these insights to individual circumstances, often with the support of knowledgeable healthcare providers, and sometimes through the resilience that emerges from understanding that we're not alone in these struggles. Until next time, may your strides toward solutions be steady, informed, and filled with hope.